So I have the pleasure to introduce Professor Robert Chin, who's a professor of neurology and an MS expert from the University of Virginia. And we are honored to have him as an invited lecturer, despite the talks on epilepsy. And his topic will be, I think it's very important for us, the gender issues in multiple sclerosis. So please, Professor.
Okay, thank you very much for the opportunity to present. Do you have a name for this dish? What is that called? What is that? Do you know? What is it? Yeah, so it's a palate cleanser, right? You eat maybe in between your dishes. And so I know this is an epilepsy conference, but we're going to have a slight side dish, and we're going to talk about multiple sclerosis, a different condition. As we heard, there is a lot of epilepsy in Egypt, but you should be aware, even though multiple sclerosis is a rare disease, there are many patients with multiple sclerosis in Egypt. I think they estimate over 50,000 Egyptians have multiple sclerosis. And in fact, in the MENA region, Egypt may have the highest number of MS patients because you have a very large population. I was asked to talk about gender issues in multiple sclerosis. You're very familiar with this condition. It's a demyelinating disease of the central nervous system. A typical MRI scan shows you many of these periventricular lesions. And I think we've all been taught very similar facts about multiple sclerosis. So typically we think of multiple sclerosis as demyelination of the brain and spinal cord, the central nervous system. We know that it's immune mediated. It has something to do with the immune system attacking the brain and spinal cord. And we know that it affects people at a young age. Epilepsy can affect children. Multiple sclerosis is not as common in children, but young adults seem to be affected by multiple sclerosis. Now, we also say, we teach each other that women are more affected than men, that there are more women with MS than men. We often focus on people of Northern European ancestry. The incidence is highest in Northern Europe, and in Scandinavia, we have a high incidence in the United States. When it comes to men with multiple sclerosis, we teach people that it is less common in men than in women, but when men have multiple sclerosis, they seem to do very poorly. We say that they have a much worse prognosis. They're more disabled. The disability accumulates more rapidly than in women, and we also know the primary progressive subtype seems to be more common in men. They present not as much with relapses, but they're just gradually worsening, gradually progressing. We should ask ourselves, are those facts true, however, the things that I just said? Is it true? Well, this is an epidemiologic study. So the United States is a very militarized country. So we have many young men and women are enrolled in our armed forces. This is a study by John Kurtzky, you may know, is an epidemiologist who helped teach us a lot about MS. When you use the EDSS, Expanded Disability Status Scale, that was created by John Kurtzky. So this is his work, his group in Washington, D.C., and they did a study. They looked at all the men and women who enrolled in the armed forces of the United States during the Gulf War era. So this means over the past 20, 25 years. And looked at these young men and women, how many of them went on to be diagnosed with multiple sclerosis. So just an epidemiologic study. I'm going to make a comment. This talk is not about race. Egypt is a very diverse country. You have people of many skin colors, many religions, all kinds of diversity here. The United States, we have a very big division between Black Americans and white Americans. It caused a lot of friction. For a long time, we focused, as I said, on Northern European ancestry. We said white individuals have the highest risk of MS. This was one of the first studies to show that may not be true. So I'm just not the purpose of this talk, but just so you know, the incidence of MS in Black and white Americans turns out to be the same. Actually, the incidence is a little bit higher if you're Black than if you're white. So just going to comment, this assumption that MS affects people with light skin color, that may not be true. In the United States, Black, white, it does not matter. The incidence is the same, actually. But for the purpose of this talk, they did observe a difference when you look at sex or gender. Okay, there were more women who were diagnosed with MS than men in this cohort. Okay, so that statement appears to be true. About 2 to 3 times as many women as men have multiple sclerosis. That does seem to be true. If you look at the incidence of multiple sclerosis, we see this curve, and again, you're familiar with it. Women, more common, so that's the orange bar. Men, not as common, but the bulge is in the middle in a young age group. One theory is, as I said, children do not commonly get multiple sclerosis, but young women do seem to begin to about age 18 into the 20s, a peak in the 30s and 40s, and then it seems to decrease later. Some have said, could this be related to something like maybe hormone levels? So for example, if we said that more women than men have multiple sclerosis, women have more estrogen, men have more testosterone, they said, isn't it interesting that in multiple sclerosis, it seems to occur when women hit puberty? After puberty, we see the incidence of MS go up and seems to last until menopause, when fertility goes down. So one observation, one theory, was that maybe multiple sclerosis has something to do with hormones. And as women become fertile, they begin to have a higher risk of multiple sclerosis, which remains until menopause, until they have loss of fertility. So it's kind of an observation that was made. Tied to this is looking at multiple sclerosis and its relationship to pregnancy. This is a somewhat famous article by Confavreau, published in the New England Journal of Medicine back in the 1990s. And they looked at the rate of MS relapse in women who became pregnant. And it's kind of a famous graph. I mean, this graph is now almost 30 years old. But you see that when you look at the incidence of MS relapse, it appears as though when women become pregnant, the relapse rate goes down. It is as if pregnancy protects them from MS relapse until after they deliver. And then you can see that the risk of relapse appears to go up after delivery and then come back to baseline. Again, suggesting that maybe somehow hormones are affecting the immune system. While pregnant, relapse rate is suppressed, as if pregnancy protects you from multiple sclerosis. But then when you deliver the baby, the relapse rate rebounds and then comes back to normal. So all of these are arguments that maybe somehow mysteriously hormones have something to do with multiple sclerosis. That led to a study. And so this study was out of UCLA. This is Nancy Sykott, looking at, well, if that's true, if somehow pregnancy is protective in multiple sclerosis, what if we give women with MS pregnancy hormone? See what happens. So they use estriol. Estriol is an estrogen derivative, but it's only created by the placenta. So women can only be exposed to estriol during pregnancy. It's an estrogen that is created by the placenta only when pregnant. And they gave estriol to women with pregnancy. And you may know the result. This was just a preliminary study. And it suggested that, in fact, women who were receiving estriol had fewer relapses and actually improved scores in cognition. They seem to be doing better from the multiple sclerosis standpoint. Now, again, this study is now over 20 years old. There were calls to do maybe a larger treatment trial. So far, that actually hasn't really materialized. So we're not sure if this is the case. One problem is that, of course, as I said, men also can have multiple sclerosis. It's not going to be clear that we can safely give men doses of estrogen over time. Also, as you know, it's not clear whether hormone replacement in women long-term is safe. So there are concerns even in menopause. So certainly in a pregnancy, 8 or 9 months, a boost of estriol seems to be normal. But it's not clear that this makes sense from a treatment standpoint. But again, all of these points individually suggest there's something that's different between women and men in terms of multiple sclerosis. But maybe this is all just some kind of confounder. So I don't know if you know Nassim Taleb. He's a Lebanese, but sort of a mathematician and philosopher. He has a quote, "Injecting some confusion stabilizes." He's sort of a big believer in questioning the dogma. So I'm going to ask you a question. Among these conditions, multiple sclerosis, idiopathic adrenal hypertension, lupus, neuromyelitis optica, spectrum, which of these conditions is the most balanced in terms of male-female ratio? Which of these conditions is closest to 50-50, would you say? If you had to guess. NMO, what do you? IIH, maybe lupus. Actually, the most balanced of all of these diagnoses, the one that is closest to 50-50 is MS. Okay? Idiopathic intracranial hypertension, pseudotumor cerebri, almost never affects men. The ratio of women to men for idiopathic intracranial hypertension causes papilledema and headaches associated with obesity, 9-to-1 ratio of women to men. I don't know if you know this, I do MS and neurology. I'm also a neuro-ophthalmologist, so I see a lot of papilledema. I was taught if I diagnose a man with idiopathic intracranial hypertension, I got the diagnosis wrong. My mentor said, you missed it. Something else caused that pressure. Maybe cerebral vein thrombosis, maybe sleep apnea, maybe dural AVM. I would say men almost never get idiopathic intracranial hypertension. Lupus, systemic lupus erythematosus. How often do we send a blood test, someone has some kind of symptoms, we send ANA, right? Check anti-nuclear antibody. Screening for lupus. Lupus is extremely rare in men. The ratio of women to men for lupus, again, 8-to-1, 9-to-1. Extremely rare for men to have lupus. Actually, ask yourselves, what's the last patient you ever saw with lupus who was a man? Very rare. Neuromyelitis optica. In NMO spectrum disorder trials, the ratio of women to men in the studies is approximately 90% women. Now, I think that's an underestimate. I think NMO maybe 7-to-1, something like this. So 2-to-1, 3-to-1 for MS? It's actually that's almost 50 relative to these conditions. Yet, when we learn about SLE, when we learn about NMO, when we learn about pseudotumor, we almost never talk about male-female. We don't say, oh, lupus, primarily a disease of women. We don't say NMO spectrum disorder, almost exclusively a condition of women. We don't say that. Only multiple sclerosis, some reason, the first thing we say, oh, MS, primarily affects women. So it's sort of a funny statement that it's actually not such a severe imbalance. And I kind of contrast this with another condition, kind of came up earlier. This is just a picture. What is being depicted here? What is this a picture? What is this symptom? What is this? Yes, oh, they're having a heart attack. We all have been taught, watch out for sign of chest. Well, look at the CDC in the US, our Center for Disease Control. This is just two examples of some of the material they share. Because what do we know about heart attack and stroke? In the young, technically men have more heart attacks than women, young age group. 2 to 3 times as many men as women have. Actually, lifetime incidence is equal because women live longer than men. So women eventually could have a heart. But for a young individual, the risk of heart attack is much greater in men than in women. But we learned that women with heart attack were more likely to die, have bad outcome. Why? Because we didn't recognize it in women. And sometimes the symptoms are slightly different in women. So it's interesting, more common in men than in women, but worse prognosis in women. And so to correct this under-recognition, you see the material. This is the exact picture from CDC, a man and a woman. They say symptoms like, they don't say heart attack, primarily a disease of men. You would never say that. They say, we must recognize the signs of a heart attack. It doesn't matter what your sex is. And again, this picture, same thing. On just another picture, they have a cartoon, man, woman, different races. Doesn't matter. Recognize the signs of it. Because we said, you know what, it doesn't matter if there's a small imbalance. We must recognize it equally in the group, regardless of their sex or gender. This case really brought this home to me. This is a patient in 2011, had loss of vision in the left eye, diagnosed with optic neuritis. Given 3 days of IV methylprednisolone, vision got better. He actually asked, should I get an MRI? Do I need? They said, actually, you don't need an MRI scan. It's okay. We know optic neuritis, you're fine. No MRI scan. The doctor did not order MRI scan. I met him later in 2019. Now he's 37 years old. Time has passed. He has pins and needles, paresthesias, and began to get imbalanced, so comes to the neurology clinic. His MRI had demyelinating lesions in the brain and spinal cord all over the place. He told me about the option. I said, oh, what? You didn't get an MRI? He said, no, the doctor said I didn't need an MRI. I said, wow, that's amazing. How could someone have optic neuritis and not get MRI scan? Well, I think it's because he looked like this. He was a muscular black man, tattoos all over his body, not the stereotype of multiple sclerosis. He was told the reason to not get an MRI is because you're a black man. Like, you're not going to have multiple sclerosis, so we didn't do it. So it was a error, just because he was the wrong sex and wrong race. Would that matter, though? Just eventually we figured out he had MS. It took us 15 years to figure it out, but does that matter? Well, this is just a summary. These are all different MS studies. So if I came here, I was doing a talk about multiple sclerosis treatment, and you looked at all of the pivotal trials, drug X versus placebo, high efficacy versus low efficacy. It doesn't matter. All of the studies, the data looks the same, looks like this. You see two curves. You see one group that's treated have less disability. The other group has more disability, right? And you see the curves spread out over time. And it turns out that it does not matter if you switch if you go from placebo and then switch open label to active drug, the curves never touch. Whatever disability that is accumulated in the early stages of the trial, you can never recover that, you can never get that back. So if you're just randomized to drug versus placebo, 2 years of placebo, 2 years of drug, the curves separate and they never connect. There is a cost to the delay in diagnosis. If we delay the diagnosis, that creates more disability. Actually, Dr. Gaillard had this slide. Time is brain. We think of that for stroke. Stroke, have to act quickly. But it's also true in conditions like multiple sclerosis. Maybe not on the order of minutes to hours, but time is brain. A delay in diagnosis leads to more disability. Again, how would this be relevant here? Well, we were curious. So when I was at Georgetown in Washington, D.C., we did a little survey of our patients, a very simple project. One of my residents was in charge of the project. We just asked 3 questions. All the patients came into clinic. We asked 3 questions. First of all, when did you have your first neurologic symptom? In retrospect, but think back. When was your first symptom? Second question, when did you first see a neurologist? When were you evaluated? Third question, when did you get diagnosed with MS? Okay, that's it. 3 questions. Symptom, see a neurologist, diagnosed with MS. And our thought was these points could tell us a couple different. From your symptom to seeing the neurologist, that tells you how long did it take before you went to the doctor or someone referred you to a neurologist. That's just the delay in assessment. Once you see the neurologist, how long before they diagnosed MS? Testing, visiting, how long did it take? So we just wanted to look at those 3 questions. We just had a little survey. I just gave it to all of my patients that I saw. So we offered 200-some surveys. Mostly, it was an easy, only 10 questions. They just filled it out. It was easy. So we had almost 90% of the patients who filled it out. I will say a few we didn't count in the study because they were incompletely filled out, maybe mixed race, something like that. We were actually interested in 2 areas, race and sex or gender. That's what we're primarily interested in. So I'll tell you that, and this is in Washington, D.C., the demographics of the capital of the United States. So I have the exact same percentage of black patients as white patients in Washington, D.C. So 46, 47% white, 48% black. So it's pretty equal in those categories. The female-male ratio, very similar to other studies, about 2-to-1 to 3-to-1. That's typical. Technically, yes, more women than men. And we looked at the results. These are just some of the curves looking at sort of the time to onset, et cetera. But I break it down into these tables. So maybe actually I would look at the bottom. Remember your initial or symptom, let's say at the top, symptom to visit. How long did it take you to get checked out for that symptom? You can see if you were a Caucasian woman, a white woman, that's very short. I could make a stereotype, maybe even a little tingling numbness. The woman might say, oh, I should go see a doctor. 1 month. Black women, not that different, 2 months to see a doctor. But there was a big difference. A white man might take 4 months before they go to even check. Man will be, I'm okay, I don't need to, some delay. Black men took almost a year. From the initial symptom to being evaluated could take almost a year if you're a black man. And again, could be cultural. Maybe stereotype, they don't want to see a doctor, they don't trust medicine in the United States. Or maybe, like my patient, the primary care doctor did not think to refer to a neurologist. Interestingly, at least at our center, once you came to see us, the diagnosis could be made fairly quickly. I can do MRI scan, I can assess. So not a big delay. A little bit longer for men than women, but very close. Delay really was in getting seen by the neurologist. That's where the biggest difference was. And again, we could look at different tables. We arbitrarily had a cutoff. How likely was it that it would delay from your symptom to getting diagnosed with MS? Would it take within a year you could do that? Or would it take more than 1 year before you got your diagnosis? You can see that's where the biggest difference was. Actually, race in the United States, it is a big factor, but didn't significantly delay your diagnosis. But being a man did. Men versus women, highly significant. You are much more likely to have a delay in diagnosis if you're a man than if you're a woman. Maybe because we keep teaching everyone that MS primarily affects women, not men. It just seems to be something we're not aware of. Again, what would the impact of something like this be? You can see the difference here, right? Symptom onset to visit. I say for women, median of 2 months. For men, median of 6 months. Visit to the diagnosis, not very different. If you come and see me, I can figure out that you have MS, if you can come and see me. But when you look at the whole time, from your first symptom, look at the difference. 6 months, within 6 months for a woman, you have a symptom, we can figure out you have MS. For men, over 2 years is the median score. And you could think of many patients that you may have with MS, especially the men. When you look at their history, just look at your chart. You'll see often, they had a symptom, but sometimes years earlier before they even saw a doctor or before anyone figured it out. So there's clearly a delay in the diagnosis of MS, especially for men when compared to women. All right, well, remember the facts that we were taught. We were taught that men have a worse prognosis, that they have more disability, that they're more likely to present with gradually progressive disability. And we thought, well, maybe it's hormones, maybe it's, well, you know what? What if it's not any of those things, but it has to do with this delay in assessment? And these are just some pictures we used to use for different subtypes of MS, relapsing remitting MS, or primary progressive, secondary progressive MS. I would argue that if we make the diagnosis early, we recognize the relapses and we can identify their subtype and we can treat them. But all that has to happen if we were to delay diagnosis, well, what are we going to see? We're going to see that when they present, they have more disability when they present. They're more likely to be in the progressive phase of their disease by the time we figure it out. So my argument would be that the observations that we've made are true. Men, not as common as in women, but that may not matter. And they do have a worse prognosis, but maybe it's not a biological difference. It's our fault. It's a delay in identifying multiple sclerosis. So we're taking this data, we have this actually submitted for publication, just trying to, again, kind of change the conversation a little bit, really change how we understand MS. Why would we need to? Well, because if it's true that at least some component of the observed imbalance between men and women is due to our own bias, we can fix that by changing how we talk about multiple sclerosis. And so remember the MS facts that we started out with. CNS disease, immune-mediated onset in young child. This is sort of the picture, the typical MS patient. Women more than. I would say, wait a minute. Wait, maybe we should not teach MS that way. What if we had a different way that we taught multiple sclerosis that looked like this? MS, central nervous system demyelination, immune-mediated onset in young adult. But you know what? You could be of any race. You can be any skin color. And we need to diagnose you with MS as soon as. Why? Because delays in assessment and diagnosis may be associated with outcomes. So we maybe can fix the imbalance without invoking some other kind of biological problem. Okay? All right, well, thank you again for allowing me to present.
Thank you so much for this really very fantastic presentation. And any questions? Yes, Dr. Professor Azza Ghali from microphone.
Thank you, Professor Dr. Robert, for your clear message. You taught us today a very helpful lesson. But here in Egypt, in our community, we have not a lot of information about MS among the publications. So we are not think that this point that MS is more common in female is a propagated knowledge. But instead, also still, we are discovered male with MS very late with a bad prognosis or accumulating disability. But maybe I have a point, I don't know if you will agree with me, that female, whatever their cultures, have a high level of anxiety about her health problem than male. The male is always busy about the work, something like that. But the female, I think, she may have a higher level of anxiety about her health. So if we add to this study some sort of scales for anxiety or for concern, I think maybe it will be different. This is my point. Thank you.
Thank you. Yes, that's a very good observation. If we're very honest, even though it's a stereotype, women and men approach healthcare differently in all cultures. That is true. Now, I would say, however, there is an opportunity again, because again, this idea, if I'm on stage, I say, oh, I'm having some pain. Everyone says, oh my gosh, he's having a heart attack. That wasn't always known, okay? There had to be an education program to the community to say, recognize the signs of a heart attack, or for that matter, we're neurologists, stroke. If someone develops a facial droop or slurring of speech or weakness, you say, oh, you might be having a stroke. We should, right? We had to educate people on the signs of a stroke, on the signs of a heart attack. I would argue, could we educate the community about signs of multiple sclerosis? A little bit of blurred vision, a little bit of numbness. Maybe we shouldn't ignore that. Maybe get that checked out, whether you're a man or a woman. So again, you're right, there are cultural barriers. But in medicine, we have overcome that by education. I didn't mention this, but the incidence of MS is increasing throughout the world, and in Egypt, actually, quite a bit. In men, yeah, and some of it could be, there could be a change in disease. It could be that we are recognizing it more now that we have more MRI and you have modern healthcare, and maybe we can change people's attitude. I would argue we should never talk about MS as more common in women than in men. Even if sort of technically true. Why? Why emphasize that? Maybe not as much here, but for sure in the United States, we have to stop talking about MS and race. Because again, that's actually not even true there. So, but I agree with you.